Good afternoon, everyone, and Happy New Year. It's a pleasure and an honor to be speaking with you, to welcome in the new year with some new learning. Um, Dr. Konold and I are going to be talking today on how to identify unnecessary penicillin allergies. But first, some housekeeping. Disclosure. We do not have any conflicts of interest, nor will we be discussing any off-label product use. This lecture has no commercial support or sponsorship, nor is it co-sponsored. More importantly, you may be filmed or photographed. This doesn't bother me at all. I don't find this daunting at all, that you may be filmed or photographed. All right, we're happy to share. There are two objectives for today's talk, and each of us will be taking one. The first objective is that we would like by the end that you are able to describe why penicillin allergy delabeling is important. And objective two, to identify a plan for penicillin allergy delabeling. So, objective one, why is penicillin allergy delabeling important? Well, penicillin allergies and antibiotic allergies in general are important because antibiotics are important. We use a lot of them in our patients. Over time, it has been the mission of the antibiotic stewardship program to reduce unnecessary antibiotic use, and we have done that. Since the program launched in 2013, we have gone from a place where about 45 to 50% of patients in our hospital were getting antibiotics on a given day to now we're under 40%. And at some point last year, we were down into the 30% range, and we've bounced back up a little bit. But on any given day, between 30 and 40% of our patients are receiving antibiotics, which means anywhere from 100 to 120 patients are getting antibiotics. And the infectious disease consult team only is consulting on about 15 to 20 patients. So that means there's a lot of patients whose antibiotic care we can support using other strategies, and that's what the stewardship program is here to do, and that's what we're going to talk about. Our goal is to make sure that we are giving every patient in our care the optimal antibiotic for their condition every day. So I want you to think about four things about penicillin allergies and why I think delabeling is important. Penicillin allergies are common. They're usually false or unnecessary or inappropriate. They actually have a negative impact on health, and they're easy, safe, and fun to correct. So first, penicillin allergies are common. Approximately 10% of all US patients report having an allergic reaction to a penicillin class antibiotic in their past. I just want to pause and call out this penicillin class, because we're not always talking about penicillin, but things in the class. That could be amoxicillin or ampicillin or piperacillin, tazobactam, zosyn, all the things that share the same chemical structure. So 1 in 10 Americans, 1 in 10 patients have a penicillin allergy listed in their electronic record or their medical record. That's a lot. So with 300 kids in the hospital each day, there are probably 30 kids with this label. Of all these people with penicillin allergies, less than 1 in 10 of those are actually true, accurate allergies. Most of these are not true IgE, that's the allergy-related antibody, IgE-mediated reactions. Those are the ones we care about most, because that means when you're exposed to the antibiotic again, you can have a more serious reaction that impacts your breathing, your ability to swallow. So most of the allergies that are listed are not accurate predictors of what's going to happen if patients were to get penicillin class agents again. Furthermore, approximately 80% of patients who do have an IgE-mediated penicillin allergy lose their sensitivity after 10 years. So if we consider that most penicillin allergies are probably earned or labeled on patients in their first 5 or 10 years of life, it may be that as they're getting ready to move into their adult care, they have lost the penicillin allergy. And that's just for the true IgE mediated allergies. And so we also know that when we're not using penicillins, we can end up using broader spectrum agents. And we'll talk about some of those implications in just a minute. So if we can correctly identify those patients who have penicillin allergies that are not accurate, then we can decrease their exposure to unnecessarily broad antibiotics. So that's really what we're hoping to accomplish with your help. So when a provider sees a penicillin allergy on the chart, it's a pretty knee-jerk reaction to go to something else. The first impulse is not to ask, well, what really was the reaction? Because that takes us into a place where we need confidence, we need skills, we need expertise, and we need time. And we need the right parent or caregiver there to give us the answers. And so often, as we know, one parent may say, well, mom knows. Well, that's what a dad would say. But when we see a penicillin allergy or amoxicillin allergy, we usually will just forget the whole thing and go to some other agent. What happens when we do that? We go to something broader, which increases the risk of C. difficile or Clostridium difficile infection. It's not as big a problem in pediatrics as it is in adults, for sure. But I want to remind you that not all antibiotics are created equal. This beautiful chart is one of the most striking findings about the relationship between different antibiotics, narrow antibiotics versus broader antibiotics, and the risk of C. diff. This was published a couple of years ago in one of the infection journals. Now, the patients in this population were adult nursing home patients who are at much higher risk of C. diff. It is true. But we do know that regardless of the age, when you are exposed to antibiotics, it affects the good bacteria in your gut, your so-called microbiome, the microbiota. And those good bacteria really are good. They are essential for health, for digestion, for nutrition, and for immunologic protection against other bad things in the gut. So when we look at, for example, amoxicillin here in this cohort, we see that there is some increased risk of C. diff with just amoxicillin. Nothing is quite as good as my favorite antibiotic, nitrofurantoin, which only leaves the body through the urine. It doesn't leave through the gut, so it doesn't have an impact on the good bacteria in the gut. But compared to amoxicillin, if we end up, for example, just making a simple change to clindamycin for treatment of a skin infection, look at the huge jump in risk. And more often in the outpatient setting, children who have a listed allergy with penicillin or amoxicillin may end up getting cefixime, a third-generation oral cephalosporin for pharyngitis or for sinusitis. And this also comes with a huge impact and increased risk of C. diff. And not only that, broader antibiotics increase the risk of patients becoming colonized with multi-drug resistant organisms. These alternative agents that are not penicillins may also be more toxic. There may be more adverse events associated with their use. And we know that antibiotics are the leading cause among all classes of medications in terms of leading to additional emergency department visits. So our penicillins are safer and better tolerated. Other antibiotic agents are actually less effective. We have seen that patients who come in for surgery and have a listed penicillin allergy will get, again, non-penicillin antibiotic agents that are actually less effective in preventing surgical site infection. And finally, when we get away from our beloved penicillins, amoxicillin, we may get into agents that are less familiar to us or even less available, which can lead to increased risks of incorrect prescribing in dosing or duration, or even in delayed treatment with drugs that are harder to find. Finally, penicillin allergies are easy, safe, and fun to correct. All care team members can directly modify or reduce the risk of all these negative health impacts, not only during a specific current care episode, but into the future. So inpatient providers can affect the entire outpatient course. Outpatient providers can affect what happens inpatient. We all can interrupt this cycle of healthcare misinformation in patients' charts simply by asking the medical history with specific questions. We're taught again and again during our training that we can make a diagnosis just with a great history. Likewise, in this case, with the right history, we can make the right diagnosis of an inappropriate or incorrect penicillin allergy. Importantly, we have the permission to change allergy histories in the electronic health record. We have the permission. We have the power, as well as the responsibility to improve the accuracy of allergy histories. And we know we can do this without the risk of any past reporting or past histories simply disappearing from the EHR. Dr. Connell is going to show you that the information that has been attached to patient's chart does not have to go away. So we're not going to do anything dangerous by getting rid of information. And excitingly, we may even be able to see our practice change right before our eyes as we pilot in-house approaches to delabeling, for example, with something called the oral amoxicillin challenge. And this is where the opening band plays its last song and hands off to the main act. It's my pleasure to introduce Dr. Connell.
Thank you, Dr. Weissman. I'm going to share my screen, so give me just a moment. Can you guys all see it all right? Okay. As Dr. Weissman mentioned at the top of the hour, what I'm going to talk to you guys about today is making a plan for penicillin allergy delabeling. So as he mentioned sort of in the last couple of slides, in our institution, we have developed a method for us to identify the patients who should undergo clarification of their penicillin allergy, and how to identify by those historical clues, or just questions we ask the patient, what level of risk they are for having another reaction to a penicillin class antibiotic, and finding methods that we can sort of communicate that information and push it forward so that it helps the next person. Of course, the first step for every intervention that we need to do like this is to figure out who are the right patients. So how do we figure out in which patients we need to do this kind of an intervention? And we feel very strongly that any patient that walks in the door who reports a penicillin allergy should undergo the screening right now. And that's because we can really help those patients for the future, just like Dr. Weissman mentioned. He also mentioned that when we say a penicillin allergy, what we actually mean is an allergy to the drug penicillin and any of its derivatives or drugs that are in the same class. So here in the table, you can see some examples of some other penicillin antibiotics that would qualify a patient as having what we would call a penicillin allergy. So that's how I'm going to refer to it the rest of the talk. But I just wanted you guys to know that this is what I mean. So for example, a patient with an amoxicillin allergy, with a oxacillin allergy or a nafcillin allergy, or any of the things on this table, and I'm sure there's a few more out there, but you guys are probably familiar with lots of these. And of course, even though we strive to do this for all of our patients, it is extra important in patients who you think are going to need an antibiotic, because then you could really directly make a change in their management that's coming up. So for example, a patient that you have admitted for an infection, or a patient that perhaps you're seeing in clinic or in the ER who's maybe going to get an outpatient antibiotic for home because they have pneumonia or something like that. And then also healthy patients who are planned to undergo surgery and as a result are going to require pre-op antibiotics. And we're not restricting our patient population by any kind of really underlying problem right now, because we do want to reach as many patients as we can. Right now, we have a pilot running on the MedR4 floor to sort of work out the kinks in this process. And so in those areas, we're doing some education to try to get more people to do the screening process. And I'm going to tell you guys next about sort of how we kind of go about doing that, because that's something that you all can be doing for your patients in any venue of the hospital. And we hope that we might be able to spread it more formally as time goes on. Okay, so first I just wanted to do a little bit of review about anaphylaxis. So when we're thinking about a patient who previously had a reaction to a penicillin antibiotic, the big thing that we're all scared about is, what if I give them another dose and then they have anaphylaxis? That's sort of most people's sort of like worst case scenario. And anaphylaxis, many of you guys have likely seen it in person, and it's an immune cascade that is mediated by histamine and IgE, which are just chemicals that cause this inflammatory cascade, where you can have the classic stuff many of you probably are thinking about, which includes, feeling like your throat is tightening, that your tongue gets big, difficulty breathing, and patients, if it continues, can even get low blood pressure and pass out. But there are some patients who also have things like itchy hives, or they might have even gastrointestinal effects. So the whole point of the screening questionnaire that we have put together is to try to figure out, for this patient who had a reaction to a penicillin in the past, what's the likelihood that they're going to have anaphylaxis? Because that's our worst case scenario that we do not want to have happen, right? So we're going to we have provided a bunch of questions that you guys can ask to put our patients into different sort of risk buckets. So this is just a schema of the steps that we are doing on MedR4, which I would encourage you guys to do in other places in the hospital to ask the questions. So first we have a penicillin allergy risk screening questionnaire, which I'll show you in the next couple slides. And that helps us determine the level of risk, as you can see in the next box. And you can see that there's 4 different buckets. And in the next several slides, I'm going to go through each of those so that you guys can better understand, what gets a patient placed in each of those buckets. And then the last couple of steps are to document, especially in Epic, because it's really important for the next person who comes on to have that information at their fingertips. And that's the way that you guys can make a really big difference for that patient moving forward in their phases of care. So in addition to making a change for them in the moment, what you do when you're doing this procedure can really pay off for this patient even years down the line, which we think is so beneficial. And lastly, it's really important also to communicate all of the great work that you guys are doing with this intervention. Okay, so I'm just going to go through the steps of the questionnaire and again tell you guys about the risk buckets so you can see kind of with screenshots how really easy it is to do this. So what I'm showing you guys right now is a screenshot of the Nursing Admission Navigator. And our nursing informatics colleagues very kindly built this out for us so that it's in Epic. And you can see that when you pull up your navigator, specifically the admission navigator, there is a entry for penicillin screening, just like there is for, reviewing home medications and immunizations and all that. So if you are working on MedR4, you will actually get a pop-up for any patient that walks into MedR4 with an amoxicillin allergy that says, hey, your kid has an amoxicillin allergy, please consider doing the penicillin allergy screening. Here's where you go. But for people who are not currently being admitted to MedR4, you can go into your admission navigator and find this and just fill it out. So it's about 10, 11 questions long, and it's smart. So as you ask the parent the questions and answer, put in their answers, it'll pop up, if there's another question that pulls from that question automatically, so you don't have to be like thinking about it. So these are just radio buttons, and as you click them, again, it will fill out the screening tool for you guys. And what will eventually happen when you've gone through and completed a questionnaire in Epic is you'll actually get a pop-up, which I'll show you on the next screen, which will say, we auto-calculated it for you, and your patient is in one of these 4 risk buckets. For a patient who is at no increased risk, that basically means that they carry the same level of risk as anyone in the general population who is running around, who's never had penicillin before, would have to have a reaction to penicillin. So they have no increased risk compared to the general population. And this means that they're not allergic as far as we're aware, and we can remove that allergy label, which I'll show you guys how to do in the next several slides. And then for any patient that gets put into one of these higher level risk buckets, it gets a little bit more complicated, and we'll talk about what is the best course of action for these later on. Okay, again, this is that pop-up that I mentioned where it tells they're in this risk bucket, and it also gives some instructions about what the next to-dos are so that you have a reminder. But I'm going to go through those for you guys all right now, just because I want to demystify the process and help people see how really simple it is. Okay, so the first risk bucket, as we mentioned, is a patient with no increased risk of anaphylaxis if they were to take a penicillin. And the questions that would, and the answers that would get these patients into this level of risk is, there's 2 things. So one is if the penicillin allergy is only in the patient's chart because of a family history of a penicillin allergy. So this is sort of one of those examples of misinformation that Dr. Weissman mentioned, where sometimes patients think that you can inherit an allergy to a specific agent, and you actually can't. So they might say, well, mom is allergic to penicillin, so put in a penicillin allergy for the baby. And sometimes, we may not have time to sort of clarify and better understand, and it just gets documented anyways, and then it kind of propagates. So this is a way for us to ask more about whether or not that penicillin allergy is in there because of a family history. So even though you can have parents that are kind of allergic-y kind of people, they can pass on a tendency in the child to have allergies, but you don't know what those allergies are going to be, even if, or if they're even going to have those allergies to begin with. So for example, mom and dad might have some food allergies, and the baby might just have seasonal allergies, but you can't actually inherit an allergy to like a very specific agent. So that's one scenario that gets you into the no increased risk anaphylaxis bucket. And then the second one is if the patient already tolerated penicillin in the time since the initial reaction. So for example, someone that gets an ear infection and they get put on amoxicillin and they break out on this rash, and the family's like, well, they must be allergic. So it gets into the chart, but say a couple of years later, someone decided to give that patient a different or even the same penicillin type antibiotic for another infection. Say they got a dose of Augmentin, and then they took the whole course and it went fine. So for these patients, they've basically already had an oral challenge, and so we know that those patients are going to tolerate penicillins. So for these 2 groups of patients, they can be delabeled, and you can inactivate the allergy in Epic. And then you can throw a party because you guys did exactly what we are hoping for in changing the record in Epic so that we can propagate that change and really make a big difference for that patient and save them from all of the deleterious effects that come along with getting broader spectrum antibiotics or not a first-line antibiotic. Okay, but how do we actually inactivate the allergy in Epic? So I'm going to just show you guys through some screenshots how we go about doing that, just so you're able to replicate this when you have the opportunity. Okay, so when you're looking at a patient in Epic, you guys might remember seeing this bar thing on the left-hand side, which I think they call a storyboard. I don't know who names these things, but you'll see that one of the things for patients who do have an allergy is the allergies will pop up on that bar. And if you just click the thing that says allergies, what it will do is it will pull you into the allergy workspace, which you can also get into this workspace in a different way, but this is just the easiest one. And they'll have the allergies listed by agent. So this is just an example that I pulled where a patient only had an amoxicillin allergy. And you can see that there's areas where people could have written in some comments, and some people do and some people don't. But if you want to go in and make a comment, which is what we would like everyone to do, you just click on the name of the agent, and it should pull you into this space where you have the opportunity to fill some stuff out. And what we're asking is if you all could please include a comment basically saying that, hey, I did this allergy risk questionnaire, and what it found was their risk level. And this is what we're going to do next. And you don't even have to think about what you're going to write in there, because we just made a smart phrase or a dot phrase so that you guys can just type that smart phrase or dot phrase, and it will pull in the language that I'm showing you here. So the name of the dot phrase is penicillin allergy risk. And I wrote the one where I spelled it PCN, but if you just type penicillin spelled normally, it'll also pull up. It's the same one. So when you type that dot phrase here in the commentary box, it'll pull up this chunk of text, and it'll give you the option to choose these little radio buttons. You just click which one is the appropriate level of risk, and it'll pull in the comment as you can see. So let's say that we are going to do, as I mentioned in the last couple of slides, a patient with no increased risk of anaphylaxis. For these patients, you're going to open this up. You'll type .penicillin allergy risk, and then you'll click this first radio button here that says no increased risk, and it'll pull out this comment, and it'll say, now we're going to delete the allergy record. And so that's something that we also need you guys to do so that it is removed from that bar that I showed you earlier. Because otherwise, if it stays in the bar, people are going to continue to think that that allergy is true or correct, but we want to remove it. And so the next step is to actually hit this delete button. But it's really important that you put in this comment first, because if you put in the comment and then you hit the delete button, that information, it stays in the chart. And I think that's just really important for the next person who takes care of that patient. Like, let's say the family didn't quite understand when we explained to them that they got delabeled, and then they report to another provider down the line the same amoxicillin allergy, which maybe was because of a family member with an amoxicillin allergy. And then when the next person goes in to put that into the chart or to look at their allergies, if they look at the record of the deletions, which it's like a little button that would be right down here, it's the history, they can see the date that someone last modified it and then deleted it, and then they can see the comment that you all have included here that says, oh, it's basically a it states the no increased risk, and this can also trigger the next person to go and look back at the allergy screening questionnaire that you guys all completed if they want to understand like exactly why. So we feel it's really important that this this action be taken so that this information can propagate in the chart and really help out the next provider make a really good decision for that patient so they're not accidentally adding the allergy back. Okay, so the next thing that we're going to talk about then is the next couple of risk buckets, which are the low risk bucket and the moderate risk. And as you're going through the questionnaire, it'll ask you what were the symptoms that the patient had as a result of the penicillin antibiotic. And these will, when you're filling it out, they're just like check boxes or radio buttons. And so it's very protocolized, and it's really easy to go through because you don't have to do a lot of interpretation. Like, so easy that we think even trainees could probably help fill this out. So then when it's complete, the computer will look at the results, and that'll help put it into the buckets again. And so for the low risk bucket, these are patients who only have symptoms that are listed here. So they're more milder symptoms that can be associated with an IgE mediated reaction. So things like a rash or hives or vomiting, versus the moderate risk bucket, we see that these are patients who have more severe immediate reactions, so reactions that happen within an hour, not reactions that happen like a week later. So these are where you probably associate sort of the classic symptoms of anaphylaxis, so like the wheezing and the trouble breathing and like the swelling of the mouth and the tongue and all of that stuff. So that will get you into the moderate risk bucket. All right, so what does it mean for these patients? Well, it's actually kind of difficult to say just from a history. And we know this because other people have used this screening questionnaire to look at patients who have a history of allergy and tried to figure out like how best to risk stratify. And for these patients that are kind of in the middle category, they might be allergic. But there is a way for us to get more data and to figure that out. And so the next couple of slides are not something that we're expecting you guys to do, but I just wanted to give you some background and just in case you get questions about it, or also just so you guys know kind of what the next steps would be for those patients. So traditionally, the way that we would figure this out is we would do something called penicillin skin testing, which I'll talk about more in the next slide, and then do an oral challenge afterwards if the skin testing went okay. And an oral challenge, as Dr. Weissman mentioned, it's basically just taking a dose of an oral penicillin, usually it's amoxicillin, and just seeing what happens. Okay, so more on the penicillin skin testing. For any of you guys out there who maybe like has like a cat allergy or a dog allergy or like a ragweed like I do, you may have gone to an allergist and gotten this skin testing done. And the reason that this happens like in an allergy outpatient office is it's kind of like labor intensive, and sometimes you're there for like 3 hours because they have to basically inject a control, which is the saline, something that's going to make you really itchy, which is the histamine, and then also the offending agent that they're testing you for, which if you're doing a big screener can be like a bunch of things, or if you're just doing the penicillin allergy screening, it's just the penicillin. And then they wait a little time and they see if you have a reaction. And if you don't, then they basically repeat it. So it can take a long time. And for like a little kid, this process can be like really frustrating for the children and also for the parents. So the good news though, is that there is a way for us actually to skip the skin testing nowadays and go straight to an oral challenge. And this is as a result of new literature that came out within the last few years, showing that most patients don't even need the skin testing and we can just oral challenge them right away. So we would like to try that here. We have a great group of people who are working on creating an amoxicillin oral challenge pilot here at Seattle Children's. It will be, we hope, on Med-R4, and the sort of all of the processes are getting ironed out right now, but we are anticipating that that will go live within the next couple of months. And it's mainly for floor patients who fit into that low risk or moderate risk categories. And we'll do it, like during day shift when there's a parent there and also a provider who's able to sort of help shepherd the families through this process. And if you have any questions, please let Silman know, who is one of our excellent pharmacy residents and is spearheading this project. And he just wanted me to show you guys kind of a general idea of what to expect for this, which again, it's very early days, so you will be hearing more about it in the future. But basically, the pharmacist will identify which patients are appropriate for an oral challenge on Med-R4, and then we'll ask the nurse to take baseline vitals. We'll then give 1 dose of oral amoxicillin, and then do 2 more sets of vitals separated by 15 minutes, and then see what happens. There will, of course, be a backup plan in case the patient does have a reaction. We'll have the appropriate medicines ordered and easily available. And in that case, the label must stay. But we are really hoping, and we have seen at other centers when they do exactly this, that we end up with a bunch of patients who tolerate it just fine, and then we can delabel them just the same way that we did with the no increase risk group by history. So this is just another way that we can get some more information besides the history taking and see if there are patients that we can help out for the future, really. So there will be more information about this coming up soon, we hope. Okay, now the last risk bucket I wanted to tell you guys about was those patients who end up being high risk for anaphylaxis. And these are patients that have symptoms that suggest a few different diagnoses that usually happen several days after exposure to the antibiotic. They're usually not immediate. So you may have heard of diagnoses like Stevens-Johnson syndrome or toxic epidermal necrolysis or DRESS or serum sickness. And these patients often have they may or may not have a fever. Sometimes they have weird skin rashes, but then it peels and people are usually very uncomfortable. And lots of people also have some more systemic symptoms that you can pick up on abnormal labs. So these questions are included in the questionnaire, and important for us to understand who these patients are, because these are patients in whom we should be continuing to avoid penicillins because they have a very high risk of having another episode of these kind of symptoms or anaphylaxis if they were to get another penicillin. So their allergy will remain, but we do want to modify it just to add more information so that the next person that comes on can use that information for the future. So I think that's what we're going to talk about next. So we have already done the allergy risk screening questionnaire. We've determined which level or bucket that they're in. And the next thing to do is to modify that penicillin allergy. And so you guys already saw me show an example where we're deleting the allergy, but again, we're first adding a comment so that the next person is able to use that information. And so for the low risk, moderate risk, and high risk, we're not going to delete it, but we are going to comment. So it's the same smart phrase or dot phrase that we used for the last one, penicillin allergy risk, and it'll pull up this option to choose which one it is. And then when you're done, you just hit accept, and then it'll save that information in the chart for the next person to use. Okay, so we finished our third step of documenting in Epic, which I personally feel like is the most important step, because then all of the hard work that you guys have done, you can show that you've done it and that you've really made a big difference for the patient moving forward. But it would also be nice for other people who are part of that patient's care team to be aware of the hard work that you guys just did. So the last step is to communicate the level of risk that has been figured out. So the first thing we are asking you all to do is to just let the primary contact provider know that you did this. Whatever method of communication is your regular way of, for example, asking for a Tylenol script or something, please contact your primary contact provider with just an FYI that, hey, I did this penicillin allergy screening thing. I think you're supposed to do some next things, but the instructions for your next thing, or your to-dos rather, is in your in-basket. So when you guys actually complete the screening questionnaire and you get that pop-up, in addition to the pop-up in the background, the system is actually rigged to send a in-basket message to the person that is listed as the primary contact provider for the patient, saying your patient was just screened, via the penicillin allergy risk screening questionnaire. They're in the low risk bucket, and this is the next couple of things that we recommend you do to take care of the patient. So there's instructions in there, and sometimes our in-baskets get a bit clogged, and so that's why we're just asking that you remind the provider to go ahead and take a look and to expect that, because sometimes we worry that not everyone sees it before they're done taking care of the patient. So we would very much appreciate it if you are able to communicate with the provider, whichever way you prefer, to remind them that, that you did this great thing. The next or last thing that we are also asking be done in order to facilitate good communication is to add an allergy education handout to the patient's discharge paperwork. I think sometimes if people have time, they might add patient education handouts for different things like asthma or appendicitis into the chart. And so we took advantage of that same workflow and just created a handout that you guys can pop in using the smart phrase penicillin allergy education. And when it gets printed out, the important thing is that someone just needs to like check the box for which risk category the patient ends up in. And so if you guys could please do that too, I think that that would be very useful for the patients down the line. We'd of course hope that the primary provider is going and doing some education in person with the family and they can use this handout. But I just wanted to, as a backup, just in case the provider has not had the time to do that, I want the families to have the opportunity to read about it on their own. But we have given instructions to the providers to please go in person and have this conversation because, you know, sometimes questions come up. And I just wanted to show you guys again where you add those patient education handouts, which I'm sure you all know already, but in your discharge tab up here at the top, if you look on the left-hand side under discharge documentation, you can see that there's an area for instructions. And if you type, again, penicillin allergy education, penicillin allergy education, it will pull up the handout that I just showed you in the last slide. And that's it. It's pretty simple. All right, so by now we have completed the penicillin allergy risk screening questionnaire to ask historical questions that are evidence-based to tell us what level of risk our patients are in for having an anaphylactic reaction to penicillin. Once we have the level of risk, then we can appropriately modify the penicillin allergy in EPIC so that the next person can use that information. And for patients who are at no increased risk, we're able to modify it and then delete it to get it out of the chart. I don't know about you, but I find it very, very satisfying to like hit that little delete button. And I hope that you guys will too. And I also want to empower you guys that you can do this. I think sometimes, like especially like our interns and stuff, they even get nervous about using that delete button. But I want to reassure you guys that if you use the smart phrase we provided, the information goes in the chart, people know where they can find it, and it's not actually deleted. It's available for anyone to take a look at, and you've done a really, really big service for your patients that I feel is going to make a big difference moving forward. And of course, the last thing that we're going to do is to let the provider know, like, hey, I did this awesome thing, take a look at it, and include a patient handout for the patients to be able to reference later. So I want to give a big thank you to all of the bedside nurses that have already done this. Here are just some names of some people that work on Med-R4 who we're just so grateful that they gave us a chance and tried it out for themselves and really took the place of being an advocate for their patients with an incorrect penicillin allergy label moving forward. So we're just so grateful to everyone that has welcomed our pilot on Med-R4, and also want to thank all of you guys for all of the good work that you continue to do for your patients, because we know that that you guys care about this, and we really appreciate everyone taking the time to listen and to think about it. I do have a few more slides, and then we'll take some questions. So I want you to know that over time, we're going to continuously improve this process, and we hope to report back on some successes and if there's any opportunities for the future. We're also thinking about expanding to other units. And if there's anyone out there who would like to be a nurse champion, we would love to have you. So please email us if you're interested. We're always interested to talk to people who have good ideas and are advocates for their patients. We also want to thank the Penicillin Allergy Delabeling Champions, who these are the people who really made this this intervention work. So specifically, I want to call out our wonderful nursing colleagues. So Denise Sackinger, Ashley Van Drunen, or nursing leaders who helped sort of shepherd this along. And then we had two lovely nursing fellows, Anna Deneen and Anne-Marie Tarak, who really went out and did a lot of outreach with Med-R4. And we're hoping that Hector Valdivia, our next nursing fellow, will also be helping to push this project forward. We're also really grateful for all of the support from Allergy and from pharmacy. And I just wanted to also thank other people that have supported the antimicrobial stewardship team that you see pictured here. So I think that that's all we have for today. And I just wanted to say thanks again for taking the time to listen. And we're happy to take any questions you all have.
Thank you so much, Victoria and Scott. I do have a question about the process that you all went through to create this questionnaire, because I think, this talk was very specific to children's, and so I wonder if you needed the organization's support, because it is very scary, like you said, for even a resident to delete something from the EHR, right? And I think it's probably even more scary for a nurse to feel empowered to do the same. So what was the process, and what did you do to come up with a questionnaire to categorize the risk?
So the process that we took to create the questionnaire and also make sure that we had institutional buy-in, we actually have some colleagues at another very large children's hospital at University of Colorado in Denver, really in Anschutz, who did basically this exact project, and then they published it, and we emailed them and we said, that sounds great, can we do that too? And they said, sure. So we very much appreciated that they were able to share with us, but what was most helpful was that we had their data, so we could look at a big children's hospital that was very similar to Seattle Children's and say, okay, like, how many people did they see? Did they have any problems? Like, was there anything scary that happened? And their intervention went really well. So that was very reassuring to us to know that there were other big academic medical institutions doing the same thing and that we could really replicate it. And of course, there's also actually like a ton of adult literature out there where people are doing similar interventions and have been for years and years. But as you guys know, sometimes it takes a while for that kind of thing to trickle over to pediatrics. And Scott, I don't know if you want to talk more about kind of the institutional stuff that we did to talk to different people here and make sure that everything went okay.
Yeah, I mean, I guess probably the step that we would need to do is to talk to people in risk management. The way we have approached the work so far is that by doing nothing, we're actually letting a harm continue. So, to some extent, there is our own ethical and moral values in knowing that continuing to do nothing and neglecting allergies were allowing for harms to accrue to patients. So, there's a balance to be struck. And this is why we also, really wanted to emphasize that nothing will leave the chart, right? So that information can be reactivated with a click. And the history of how we, got to a deletion or an inactivation or a judgment of no increased risk is all available in the chart. So, that's kind of the approach we've taken so far. We know that allergies are fraught and they are not good information.
Okay. Thank you for that. And I have a second question about, let's say a patient receives antibiotics during an admission and had some mild symptoms. How soon after should they receive that oral challenge? Within the same patient visit or a later time?
So it all depends. As always, it depends. It depends on what those symptoms are. So things that are anaphylactic in appearance or in nature, obviously that's something that we would want to evaluate. The scenario we do see most commonly in hospital, and this is different than what happens in the outpatient setting, obviously, is that patients are receiving multiple medications and a reaction happens and it's hard to attribute what the cause was. So I think in those cases, it's really important that the reaction and the questions about the cause be recorded in the chart. And we do see people doing a great job with that, even saying, listing two separate agents and saying, we don't know if it was this because they were also getting that. And then we don't know if it was that because they were also getting this. so that people can make the right assessment in the future, for example, when the patient is no longer in the hospital. But it is important for that family and for all the providers to know whether it was this agent or that agent. So as always, it depends.
Okay. How would you coach parents through, let's say, they have a terrible fear of this penicillin allergy because somebody in their family had it and they had a terrible reaction. Now their child is exhibiting, mild symptoms that may be an allergy. So what can you say to parents to coach them through and say, this oral challenge is okay to do?
So when I have this conversation with parents, which I've done a whole bunch of times before, the thing that I emphasize the most, there's two things. One is sort of the bad effects that come from forever having a penicillin allergy label on your chart for the rest of your life, which I don't know if we talk too much about specifics, but, like having to get a second line agent, which then can give you C. diff, or maybe doesn't work very well because it's second line, or it like kills off your microbiome. So all of these bad things, I make sure that they're aware that there are side effects to broad spectrum antibiotics, because I think that sometimes there's like a myth out there that the broad spectrum antibiotics is like the good stuff. And so we sometimes have to do a little bit of correction. So it's more of an educational thing. But I think the thing that really helps people feel more comfortable about this situation is assuring the parents that the hospital is literally the safest place to try this out. So, most people are not in and out of the hospital a whole ton. Some people are, but if someone is here in the hospital and you are like not sure whether or not they're allergic to something, this is the time to really try it out. Why? Our nurses are amazing. They are going to notice if you have a reaction immediately, and they will stop everything and they will go talk to the provider and we will figure it out together. And we're also in a place where if a bad thing happens, we have the drugs to fix that right there. And we have the ICU right down the hall. And so, like the prospect of like needing a drug and going to the ICU, certainly they can be very scary for families, but I feel like I try to communicate that this is the best place for us to be figuring this out now, instead of the patient being in a situation down the line where we're having to treat them with an antibiotic and we're like not sure what to do. And some providers like, let's just give it to you like, at home and see what happens. Because sometimes people do that and sometimes it's okay. But if we have a very anxious parent, you want to be doing that someplace where you have help right at bedside. So that's sort of the talk that I have with the families. And, everyone is different in terms of how comfortable they are with it. But I feel like as we continue to talk about it more and correct misconceptions, people become a little bit more comfortable with the idea.
Mm-hmm. Thank you so much for that. And I see a hand raised, SCS 1105. You can go ahead and come off mute if you want to ask your question.
Hi, this is Julie. I'm calling from our South Clinic in Federal Way. I'm asking how you anticipate this being used in outpatient clinics, because we prescribe a lot of antibiotics via outpatient. And we don't have access to the services that you were just talking about being in the hospital. So if you could help clarify how you would anticipate us using that would be awesome.
Absolutely. When it comes to like the structure of the questionnaire in Epic, we don't have it quite available yet, but what we are hoping to do is to just like make a paper form that's available on the intranet that you all can download and fill out with a family together if the opportunity arises for you to clarify a penicillin allergy. And then when it comes to, figuring out which bucket they're in and then doing some counseling with the family, I think it will depend upon, which of those levels they're in. So if they're in the no increased risk level because the allergy is just a family history, or they already tolerated a second dose of a penicillin antibiotic, I think it's very easy to reassure those families just with like educational talk in the outpatient clinic about like exactly what that means. And I, in the past, have felt as a resident that went pretty well for me. Although sometimes there are families that are like, well, the next time that you try to prescribe him an antibiotic, can we just like give him a dose while he's in the office? And, if your clinic is comfortable with that, some places will do that because we know that their risk level is the same as any other person running around. So things get a little tricky when you have a patient that ends up in that middle, those two middle buckets, which are the low risk and the moderate risk. And those are patients for whom I would not recommend that you do an allergy trial, like an oral amoxicillin trial in the outpatient clinic, but I would actually recommend that you refer those patients to allergy. So it is an extra couple of steps, but this is because the allergists for years and years and years have been doing oral challenges in their office. So every office is a little bit different, but many allergists will still do the screening test, do the scratch test on the arm where they're injecting, the little bubbles of the penicillin, watch the patient, and then they'll do an oral challenge in the office where the allergist is prepared to resuscitate a patient if they undergo anaphylaxis. So they are the trained people who do deal with this, and that's sort of how I counsel those patients who end up in that middle risk bucket, because many allergists do offer this service to their patients.
That's a great answer. I would tag on to that, and thank you for the question, Julie. Because we're always in the hospital, we're always coming up with great ideas that are impossible to do even in the hospital, let alone in the outpatient setting. But I would add that problem visits in the ambulatory setting, it's hard to find the time and the bandwidth and the receptivity of a family to be doing this kind of work there. It seems as though, well child visits when things are calm and kind of the whole landscape of the child's health is being considered may be a better time than a problem visit. And the other part, that you may be able to lean into even in the problem visit is just at the time any allergy, any drug allergy or any allergy is entered into the chart, getting as much specificity as you can, dates, duration, trigger, like, how long between the exposure and the reaction, putting the most accurate, specific, concrete data in there at the moment where it's, where the family history is maybe freshest, is also a gift and a contribution to being able to figure that out at a time where it's, where it's calmer or quieter.